I am Matthew Abbott, and my wife, Alana, and I run Abbott Family Insurance here in Florida. We help employers design tax smart benefit strategies so you can take better care of your people without letting payroll and benefit costs run the show.
Today, I want to tackle a question I am hearing more and more from business owners, especially in the trades and home service world. What can we actually do about high cost specialty medications?
You see it in your renewals. One or two people on a specialty drug or a GLP-1, and suddenly your pharmacy line blows up. Your people are not doing anything wrong. They are following what their doctor prescribed. But from your side of the table, it feels like you are writing a blank check.
So let us slow this down and put a frame around it.
First, what are we even talking about when we say high cost specialty medications? These are usually complex drugs for things like autoimmune disease, cancer, MS, hemophilia, and now GLP ones for diabetes and weight management. They are often life changing medications. They are also medication claims that can run thousands or tens of thousands of dollars a month. They are a small slice of prescriptions, but a huge slice of total pharmacy spend.
For a 10, 50, or 100-person shop, it does not take many of those claims to move the renewal.
The question is not, do we care about people on these drugs? Of course we do. The real question is, how do we build a benefit strategy that supports people who truly need these meds without letting three prescriptions hijack the entire plan?
Let us start with the first lever you control: how these drugs are used.
On the medical and pharmacy side, that looks like real utilization management, not just a rubber stamp. You want appropriate prior authorizations, especially for the highest cost categories. You want step therapy in place where it makes clinical sense so people try proven, lower cost options before you jump to the newest, most expensive drug. And you want your formulary pushing toward generics, biosimilars, and lower cost equivalents whenever that is medically appropriate.
The goal here is not to block care. The goal is to make sure the highest cost medications are being used where they actually deliver the most value, not just because they are heavily advertised.
The second lever is your pharmacy benefit and PBM setup. Your PBM and carrier relationship has a huge impact on what you actually pay for specialty medications. If you are on a model with opaque spread pricing and murky rebate terms, you have no clean way to see whether the plan is being managed in your interest or in somebody else's. You want as much transparency as you can get for a shop your size. That means being able to see real ingredient cost, how the specialty pharmacy is paid, and how much of the manufacturer rebate money is actually flowing back to your plan.
You also want good site of care management for infused or injected drugs. The same infusion can cost very different amounts depending on whether it is done in a hospital outpatient setting, a lower cost infusion center, or even at home. Steering to the right site of care can save serious money without changing the medication itself.
The third lever is how you handle GLP 1s and similar categories. The old way of thinking is we either cover these or we do not. That all or nothing approach is breaking down as more people ask about these drugs. A more strategic approach is to carve certain high cost categories out from the open ended medical plan and handle them through defined employer allowances or specialty benefit buckets.
For example, you might say, we will support GLP-1s for people with diabetes or specific high-risk metabolic conditions under clear clinical criteria. We will not just open the door to unlimited weight loss scripts with no guardrails. Or you might set a defined annual support amount per eligible member, so you are capping your exposure instead of writing a blank check.
The point is, you set the rules. You define who qualifies and how much help is available instead of being passively billed whatever the pharmacy system sends your way.
That is very similar to how we think about SMRP and other structured benefits. We are not saying yes or no in a vacuum. We are saying, here is the bucket, here are the rules, here is how we will fund it in a tax smart way.
The fourth lever is integration. Specialty strategy cannot live on an island. For a trades or home service employer, the way I want you thinking about this is as one integrated stack.
At the foundation, you have your core medical and pharmacy plan, which needs real specialty management baked in, not just a generic off the shelf formulary. On top of that, you build your SMRP based medical reimbursement structure and your supplemental benefits. Those pieces are there to catch the financial shock from major medical events, so families are not taking on debt or panicking every time a big claim shows up. Then, for categories like G, L, P1s, and other very high cost therapies, you decide whether a carved out, defined allowance model makes more sense than letting those claims run wild inside the main plan.
When you put those pieces together, you move from we are getting killed by one drug to we have a strategy for how we will participate in these costs on our terms. So, what do you do next as an owner?
I would start with a simple 3 step conversation with whoever is helping you with benefits. First, ask to see your specialty and GLP-1 claims data, even if it is summarized. You want to know how many people, what drugs, and how much of your total spend those categories represent.
Second, ask how your current PBM or carrier is managing those drugs. What are the prior auth rules? Are there step therapy requirements? Are there lower cost alternatives on the formulary? How are rebates being handled?
Third, talk about what a more structured approach would look like for your business. That might mean tightening utilization management, moving to a more transparent pharmacy model, building a SMRP structure that helps families handle the financial shock, or setting up defined allowances for select categories.
The reality is, you are not going to stop specialty drugs from existing, and you should not want to. But you also do not have to accept unlimited, undefined risk as your only option.
If you want help looking at your own situation and turning this from a scary line item into a strategy, reach out to us at Abbott Family Insurance. We will walk through your numbers in plain English and help you decide what makes sense for your people and your budget.